other one, substance use and domestic violence, a public health crisis. We will start with our invocation from Dr. Kathy Littles. Dr. Littles, the mic is yours.
Thank you, Sister Rochelle. Please join me in prayer. Lord, we thank you for this beautiful Saturday morning and for another day to do your work on this earth. We thank you for your grace and we thank you for your mercy. We thank you for bringing us all together to talk about mental health. Lord, there are so many people hurting. But we are guaranteed that the presence of God is with us through every challenge and struggle we face. We ask for your guidance as we search for solutions and understanding grounded in your love. We know that all things work together for good to those that love God. The grass withers and the flowers fade, but the word of our Lord endures forever. Amen.
Thank you so much, Dr. Littles. We will now have some welcoming words from Deacon Harold Goodman, Chair of our Health Education Ministry at Allen Temple Church.
Good morning, Allen Temple family and community. We're extremely delighted to be able to present to you this important information. On behalf of our senior pastor, Dr. Jacqueline A. Thompson, and our Pastor Emeritus, we would like to welcome you to this event. We are truly grateful that you've taken time out of your busy schedules to listen to these outstanding presenters. May God continue to bless you and you take the information that you received today to help others and yourselves. Thank you.
Thank you, Deacon Harold. Now, before I introduce our first presenter, Dr. Lorna Kendrick, I want to let everybody know that you can put questions into the Zoom chat and also through Facebook, and we'll try to get to all those questions as we change from session to session. So now let me tell you about the fantastic Dr. Lorna Kendrick. She earned her PhD in nursing from UCLA with a focus on depression as it impacts risk to the immune and cardiovascular systems. She worked for many years in neurosurgery ICU as an advanced practice child, adolescent, psychiatric, mental health clinical nurse specialist, maintaining a small private practice while working in academia for 27 years. As an academician, Dr. Kendrick earned tenure and full professor status and is currently serving as Dean of the Samuel Merritt University College of Nursing. She completed the Executive Leadership Program at the Wharton School of Business. Dr. Kendrick has combined experiences in both quantitative and qualitative research. Those experiences include bench science work in immunology, C4 cell line, as well as ethnographic field work and participatory action research with young African-American men. She is a native Californian who enjoys time with family, travel, hiking, off-roading, gardening, DIY projects, old movies, and audible books. She is the current archival secretary for the Council on Nursing and Anthropology. Welcome, Dr. Kendrick. The mic is yours.
Thank you so much. And I'm sharing my screen now. And let me get us into slideshow mode. Good morning, everyone. It's a delight to be here and it's an honor. And I'm looking forward to sharing some information about depression this morning. And so we're going to start. And I just wanted to mention this. All of us, I'm sure, know the story of Job, and we think about the things that Job went through and the things that he said. And because of time, I won't necessarily read the text, but I want you to take a look at the text. Think about the words that Job says in that text, because you hear so much depression mentioned there, symptoms of depression. And with symptoms of depression, sometimes we begin to wonder, where is God in our lives? And we forget, because depression changes so much in our lives. So I wanted to start with that. Hopefully you will go back and read Job 30, 16 through 31. But what I wanted to start off with is a few facts. And one of the things that you heard in my bio is that I worked with young men, and I focused my whole dissertation on perceptions of depression among young, more affluent African-American men. And what was happening at the time that really prompted me to want to do this is, at that time, I want to say early 1990s, the suicide rate among young African-American men between 15 and 25 had increased by 119%. I am the mother of 3 children, 2 of which are sons, and that was devastating for me to hear that information, and I wanted to do something about it. I think as a person of color, it's important for us to focus on things that impact our own communities, and that was something important to me. You know, I didn't want to see, I saw so many, we see in the news to this day, so many young African-American men either dying by suicide or dying by police. And I, as a mom, just couldn't even fathom having to deal with that for my son. So that's why I focused my research in this area. The other thing that I noticed is after I became an advanced practice nurse in psych mental health, because that was not my area before I worked neuro ICU, I noticed that a lot of people of color were being over medicated because of fears by many of the practitioners that were working with them. Too often they were also misdiagnosed. You'll often think about, instead of our kids being noted as having depression, it's usually conduct disorder or something like that. And those things concerned me, bothered me as a parent and as a person of our community. And what we know is 15 million Americans are diagnosed with depression. And that's diagnosed with depression, and there are many that don't have full array of depression, but they do have symptoms that can impact their lives as well. The other thing is, because my specialty in mental health is children and adolescents, what's interesting is for many, many years, no one realized that children could be depressed. They thought it was an adult disease, and so again, a misdiagnosis for children. Some of the things so you hear that I talked about perceptions of depression, and one of the things that was interesting to me in my research, often in the literature, they talk about depression being a part of natural everyday experiences, family challenges. But within our community and with my research, I didn't find that it was family challenges or problems within relationships within families. It was really, for me, one of the things, the number one issue for the young men in my study was police stops. Police stops caused them to have major depressive episodes that they could not recover from. And so perception is important. You know, I wondered why people were not being diagnosed if they were people that looked like me. Why were we not being diagnosed with depression? Many other people were being diagnosed. We go into the hospital and say, well, I don't know what's going on, but you really don't qualify for the depression of major depressive syndrome. So that really bothered me. But I also want to always kind of go back and help people understand this continuum of depression and what does that mean? Because too often we look for symptoms and say, oh, you're depressed because you meet these criteria. But people can be depressed because of other criteria as well, and they can move in that direction. But what happens is, if we have the right coping mechanisms and we've learned over time how to cope well, then we tend to recover a little bit better. I have this continuum here so that you can see mental wellness on this end, mental illness on this end. What happens is most of us kind of fall somewhere here in the middle. And depending on what goes on in your life, you can move in either direction. You think about how you feel if you've lost a loved one, a parent, a child. You start moving in this direction. The sadness, the inability to eat, the inability to sleep, the inability to get up from bed because of that deep, deep sadness that's there. We always know that if we take some time, over time, we're always told over time, we start to move back toward the center here because our coping strategies kick in. We go, we talk to family, we spend time with family. We have wonderful rituals in our culture that allow us to have family around us when we have losses and when we're going through things. We depend on family and friends, those conversations, those walks, bringing food to family members when they have a loss, all help us move in that direction. That community power is enriching. And so what often happens though is we may not have the coping strategies and we may stay stuck over here for a while, right? And when we stay stuck, sometimes we do need medication. Sometimes we do need some therapy or some treatment or some intervention to help support us to get us back. I worked with a student once who believed like I did. We tried very hard never to give meds, but oftentimes depression, because you think about all the things that happen in our body that change, and we'll talk about that a little bit as well. When things change in our body, we can't just use talk therapy, we need medication. So something interesting that came out of my study is those young men said, if you're a young man of color, you live in the US, depression is a fact of life. That was huge for me. No one had ever written that before. No other studies had discovered that before. So what does that say when it's time to move forward? They just think it's a fact of life, and either I can pull myself up by the bootstraps or I can't. And then we know that we have another speaker today that's going to talk a little bit about substance abuse, and that's that self-medication and trying to treat yourself, right? So let's move on a little bit to causes. My research is kind of dual because I looked at cell lines, bench science work, and I also looked at qualitative work. What we discovered and we started looking at when I did the bench science was, many of you have heard of the CD4 levels when we talk about HIV/AIDS and people's immune systems being so depleted that they can't really heal or they can't fight off the disease process. But what's interesting and most people don't realize is with depression, CD4 levels are decreased just as much. So you think about what our grandparents and sometimes our parents told us, when you're going through stressors, be careful because you'll probably end up sick or you'll have a cold. I had a really stressful week and now I have a stuffy nose, and that's my truth this week, right? And so I've been resting and doing all sorts of things to try and counterbalance that stressful week because I don't want this to become a full-blown cold or something. We've heard, many of us, about the neurotransmitters and the depletion of certain neurotransmitters, genetics, and here's the part that people don't always think about. Constant abuse, constant racism, the things that we deal with on an everyday basis because of the color of our skin causes depression. And you think about what those young men said in my study, it is a fact of life. And over time, it can deplete our health. We are at risk for early onset cardiovascular disease because of these things. And how do we find these opportunities to be well and to care for ourselves? Because think about us, we care for everyone oftentimes but ourselves. How do we do this to give our immune systems that boost that they need to get past the depression? Stressors, of course, substance use and addiction, finances, and chronic illness can cause depression as well. These are just some typical symptoms that you've probably heard of when you think about depression, the persistent sadness, emptiness, those kinds of things, right? Feelings of hopelessness, guilt, decreased energy, difficult sleeping, and don't forget that issue of what we see when we watch the news and we see what's happening to Black people, Black men and women and children in our nation, that can cause depressed feelings. And what do we do about that reality that we're living in? The other thing is, I wanted to mention, I did a lot of research with men and we talked about the fact of life and some of the things that police stops, but here are some things to think about when it comes to women in general. There's a constant feeling of generalized anger. And I said something recently to a friend and I said, yes, they always want to say something about angry Black women. And I said, yeah, I am angry. So stop doing those things to Black people to cause me to be angry. Instead of taking it on, accepting it, I'm pushing back and say, you're not putting that on me. I have every right to be angry if I live in this society, right? And so instead of taking it in, and what we often call that fetal position, letting that depression just pull us into that fetal position, and we start to let it eat away at us instead of fighting back and saying, I have every right to be angry living in this society, right? So how do we change that so that we can be well and not allow it to destroy us, right? Inability to advocate for oneself. As I said, I had a rough week and I had to ask someone to advocate for me because I was just too emotionally drained to do it for myself. But that again is wellness, right? I can't do it, someone else do it for me, instead of just allowing myself to go into that fetal position and feeling very sad. Women's health, we're at risk because of menopausal symptoms, of physical abuse, single motherhood, lack of resources. We have to think about these things and realize that many women living in these situations seem like they're doing quite well, but they could have what we consider kind of a minor depressed state. But how do we help them? How do we support them? How do we help move them away from that? And when we think about the continuum, how do we get them back onto that mental wellness side of the continuum, knowing that these things bring depressed symptoms to them? And how do we prevent them from becoming diagnosed with a major depression? We can do things in our community. We can do things in our churches to support that. Constant exposure to racism. One of my colleagues who attends Allen Temple and I are colleagues, and we fight this every day at work together. Mood swings. Sometimes you're doing well, and I want you to think about when someone is irritable. That's a symptom of depression. We think about sad mood, but irritability is also a symptom of depression. Feeling out of control, loss of power, loss of authority in one's life, and at least twice as likely to experience an episode of major depression as men are, twice as likely. Here are some things I want to always leave with any audience that I talk to about depression. Suicidality is real, and we can do something about that by paying attention and recognizing it. And here's something that I want everyone to remember. If there's been a family history of suicide, the likelihood of someone else in that family using suicide as a coping mechanism is greater. So be aware. When we see substance abuse and alcohol abuse and money problems, all of those things, and especially right now, kind of in the midst of us coming out of COVID, people have been alone. People have been by themselves oftentimes. People have been struggling with this, being away from other people, and the likelihood of people not being well is great. And so it's important for us to ask those questions of them. How are you doing? And here's the funny thing, not funny thing, but an interesting kind of thing to think about. Too often we say to someone walking down the street, hey, how are you? Someone says, not good. And oftentimes you think about it, you keep walking and you don't stop. And because of my work, when someone tells me not good, I just stop in the midst of wherever I'm going. And I said, wait a minute, you said not good. That bothers me. I need to hear more about this. We can't be afraid to avoid because we don't know what to do. Even if we stop and say, I heard what you said, tell me more about it, that alone can help someone cope and move on with their lives and do better. Those small moments make a huge difference. This is a slide that talks about what I said earlier, increased risk for cardiovascular disease. We have more hypertension in our communities because think about what those young men said. Depression is a fact of life for us. Even though we're coping well, some of us are coping well, some are not, but it's a fact of life. So that means it explains that cardiovascular disease in our communities. It alters our ability to make good choices. When depressed, We're not able to listen to reason. So you can't tell someone. I had a young 16-year-old that told me he didn't care what I did, he was going to complete his suicidal act, because for him, those feelings that we would consider good feelings felt uncomfortable. They were not his norm. He didn't feel comfortable in that. So he didn't want to live. But we were able to do some work with him and get him there. But they can't often listen to reason. So I'm going to give you some tips on what to do when someone is feeling that depressed. Of course, I think about self-medication. People are not often able to say no as easily at important times. And when we think about our youth, they're greater risk for STDs, unplanned pregnancies. And so if we are depressed and we're not doing anything about it, we teach our children around us that depression is the way of life. It's contagious, right? It's a learned behavior. So we have to, even if nothing else, we have to get treatment for our children. Had a patient once who came into one of our clinics who had been at the World Trade Center during September 11, and he was so depressed. And the one motivation that kept him in treatment was his child, right? His child. So here's the thing. What do you do? How do you help? Don't be afraid to ask the question. You know, there is this thing where people think if I talk about suicide or I talk about depression, it's going to cause a person to maybe try to harm themselves or be more depressed. No, it doesn't. They need your help. They need your compassion and your love and your kindness. And even if it means just sitting with them and listening to them or crying with them, pay attention to the signs. Remember what I said, it's not just a sad affect. It's irritability and a change. Are they more isolated? Are they not wanting to answer your calls? Are they not texting you? Are they saying things? I recently had someone send me a text and say, just haven't been doing well during COVID. And they had the word suicidal, and I picked up the phone and called them immediately. I said, you can't say those words to me and think that I'm going to ignore it. I can't do that. And that's the way we should all be with those around us. Prayer is sometimes not enough for this person, but I always say this, it will help you help them. There have been many times in the middle of a session that I've said in my mind, Lord, help me, because this one is really hard for me and I don't know what direction to go. Help me, because God is faithful. And so, and if they're willing, always pray with them. And here I'm almost done. I'm watching my time. A few important facts to remember. Depression does not have to be a fact of life, but if it's unresolved, it can lead to death because of suicide and cardiovascular disease, right? And then suicide is a result of unresolved depression. That's something important to remember. We think, oh, it's just a sadness. Oh, they'll get over it. Oh, they'll be fine. No, they may not be fine. And we don't want a life to end because we miss the signs. And if you are someone you know seems depressed or easily irritated, stop. Remember what I said earlier. When someone says, I'm not doing well, I stop. I listen and I ask. Don't be afraid to do that. But here's what's important, and you see how big the letters are. Do not leave them. Call for help or take them to a healthcare provider. Please do that. Important resources, and I will share these slides with everyone at Allen Temple so that if you need these resources, and I'm sure this team has the resources because of their mental health work, but just in case you needed some resources, family, trusted friend, counselor, there's NAMI. And the reason I mention NAMI is because I have had colleagues that I've worked with who've had family members that it's taken them 10 years on average to get the right diagnosis, the right plan of care, and the right treatment. And so NAMI helps to advocate and work hand in hand with the family member. I think about how many times police have to be called before someone gets the real help that they need. NAMI really works with families there. So it's a really important resource. Of course, substance abuse and mental health services admissions, and of course, 911. Don't take it for granted. Finally, that's it. And according to my timing, I have about 4 minutes, but I thought I didn't want us to not be able to get through all of the slides, but I will stop now and allow time for questions. And thank you so much. And I hope this has been helpful to you. One caveat is I did send an article related to my research to Deacon Harold, and he's going to send that out later today for you, just for an added resource. So thanks again. And I'll stop sharing my slides. Any questions in the chat? I haven't been keeping up with the chat.
So you can also raise your hand if you have a question, if you don't have to type in the chat, but I do see that there is a question in the chat. It says, great presentation and thank you. So I have a question. When you encounter somebody that has depression, they're often in different stages. And you don't ever know what that stage is. You just can kind of see that you got to do something. And it's often hard to find out what to say to them. Or better than that, what not to say. If you don't want to say how you doing, because clearly they're not doing well.
Well, you know what though? Sometimes they do want that question asked. Or you can say, are you doing okay? I've noticed, right? Or sometimes it's just best to say, I've noticed some changes that really concern me. And you put it on yourself. Instead, and when I was growing up, my mom taught me about I messages. So I noticed this and it really concerns me because I care so deeply about you. Can we talk about what's going on, right? That may be the better option than how are you doing? Because you want them to talk about it. And they may say it's really hard for me to talk about, or I'm not ready to talk about it, or I've just had some hard things going on lately. But if you say, well, let's sit together. You want to do something together? Can I spend some time with you? Do you mind if I call and check on you on occasions? And people really appreciate that.
Okay. Do we have any hands raised? I'm not seeing any.
I don't.
I have a question. With the drug use by the youth being so prevalent, have you been able to see if that's because of depression or just the freedom of drugs being so liberal?
You know what, that's a really great question. And what I've noticed in my practice and what sometimes you'll see in the research is that you can tell what mental health diagnosis, DSM-4 diagnosis, people have by the drug of choice. So if they're depressed, they usually need something that's going to perk them up a little bit, right? If they have maybe a bipolar disorder and they're really kind of manic, they need something to calm them down. So oftentimes when I'm doing an assessment and I'm asking about substance use, I can kind of picture what may be going on with them depending on that. Too often when it's a young person who starts, you think, oh, is it peer pressure? Oftentimes they really are trying to hide from something, right? And it can be family challenges, family conflicts, it can be abuse, it can be so many things, but that's what I've noticed in my practice. And there is data to support that belief and that. Yeah, so, and I'm hoping that when we hear the presentation in a few minutes on the substance abuse, he may speak to that as well. But I have noticed that drug of choice tells me if they're depressed or if they're having mania or whatever else is going on, and it helps lead my questioning with them. I hope that answers your question.
You know, some drugs are really inexpensive versus the more expensive ones.
Yes.
It used to be cocaine versus crack.
Yeah.
Yeah. So those without the money used crack.
Yeah. And you know something else I'll tell you from my research, one of the young guys said, I'd rather self-medicate than to be zonked out on the meds that they order for me. Or if I'm stressed, I see it on TV all the time. Somebody comes home, they have a glass of wine. Why can't I, right? So there's this kind of normalcy of, it's better for me to do that than to admit I have a mental health disorder. I'm challenged with something by taking meds that the doctor prescribes for me for depression, right? Those were some of the things they actually said during our focus groups as well.
Thank you for that. We do have a couple questions in the chat. It says, COVID has had a tremendous impact on young children's mental health. What's your advice for parents, providers, and teachers?
You know, I think that's a really good question. And I think sometimes we don't talk to kids, right? We think, oh, they're kids. They're just kids. They won't get it. They won't understand. We need to talk to the kids about that. It's like, I bet this is hard. How are you doing? Do you need to go outside and play for a while? I know this is rough. What can we do? You know what? Take a break, because think about what adults are doing. I can't sit at my computer all day. I need to stand. I need to this. I need some wellness, but they're forgetting to do the same things with kids. And one of the things that I notice is if a child has a loss of a grandparent, a loss of a loved one, adults, parents don't often want to talk to the kids openly about what's going on. So kids tend to make up ideas and things when they're not talked to openly and honestly. So I would say have some family meetings with them and say, how are you doing? And tell them, share. I'm not doing good myself. I can't imagine that you would be doing well. And it opens them up to conversation. And I've suggested this to parents, and they have told me it's made a difference, because they forget sometimes that the kids are struggling, and then we tend to not know what to say, so we don't say anything. It's better to say the wrong thing than not to say anything and say, oops, I probably shouldn't have said that, but I was so worried. I just had to say something, right? Rather than letting it go unspoken. So hopefully that answers that. I see another question as well. How to address those who may present with high functioning. Well, you know what? Here's what I believe it. And that high functioning has been a recent term that's being used. It's still depression. And we saw on the news recently where someone had supposedly high functioning and they ended their lives, right? So high functioning is just a term to say, well, they seem to be doing well, but guess what? It's still depression with the same risk factors as major depression, right? So hopefully that helps too.
So there's another question that says, although at least 2/3 of Americans are overweight, Black people, especially women, seem to medicate with food when depressed. Black women in my mother's generation would often say, I earned this weight.
Yeah.
Are there any studies that address the overuse of food by Black?
Oh, yeah. Oh, well, I don't know if it's necessarily, I have to remember now. I
Black
haven't
women
seen.
to treat depression.
Right. So with Black women, what they talk about overeating, I remember a few, because we've had these conversations, but historically the DSM talked about lack of eating, but more recently in the last, I don't want to say 15 years, yes, overeating has become another issue that we've addressed, identified, and are beginning to treat now and talk about. And yes, you're so correct. It's either overeating or undereating. Any one of those, anything that's in excess, we really need to look at as far as treatment and how we help people make sure they stay, when we look at the continuum, in the middle and close to mental wellness.
So another question is, you mentioned depression driven by external factors like racism. How would you address depression driven by interracial family factors?
This is treatment. We have to have some treatment. I think too often, we just think, well, we live in America, or this is our family of origin. We have no choice. We just have to deal with it. But no, we have to get treatment. And I always believe in talk therapy, and coming in to see a therapist that looks like you, maybe, that can understand what you're going through. There's so many things that can help you cope with that, because family of origin issues that you leave untreated, they grow and they get worse. and it could cause you to have the same early onset cardiovascular disease processes as well. So anything that causes someone to have feelings of sadness or irritability need to go in for some treatment. And I think that's the one thing that we tend to do in our own communities is think, oh, I can deal with this myself. I don't want to go and say I have to have therapy. We need to normalize therapy because, as I said, if you have hypertension, most of us typically will take our meds. If you have sadness, most of us want to stuff it under the carpet, pretend that it's not there, and think that we should still be able to live our lives just as well stuffing it. And we can't stuff it. We have to go in and do some talk therapy. And sometimes it only takes a few sessions. It can take 4 or 5 sessions, and you have enough coping strategies to keep going, right? So please, I just beg of people to normalize therapy and not be afraid of it.
So speaking of therapy, how should we view the DSM given the racial stereotypes often associated with what diagnoses are given?
You know what's interesting? I think it was last year, last year, 2021, I attended the Psychological Association meetings, and they apologized for many of the diagnoses that were historically placed in DSM, and they said they could never do that again. And they have written a white paper saying that they will never allow racism and stereotypes to mar the DSM. And so there are a lot of people of color now on those committees and working in those areas to say, let's look at this again. And so I'm glad that a change has occurred. And many of us, I'm thankful that when I did my training, I had a Black woman as my mentor training me and telling me those nuances. How can you treat a child whose mom is on drugs and the child's going to school and no one's combed her hair and no one's helped her take a bath? You can't treat her sadness until you take care of her, teach her how to comb her hair, teach her how to take her little shower and help her cope with just the life experiences before we can even get to the other piece. But yes, the more of us in there and as therapists who can help our community, being committed to being there to help our community. And, and a lot of times I see patients pro bono because I know if they had to pay me, they wouldn't come. But also if I didn't look like I do, they wouldn't come. And so, we have to do our due diligence and what we can in our community to make a difference and to understand and to not necessarily always use DSM. Because for me, DSM didn't always talk about irritability. For me, I saw irritability in my community, and that's what helped me see that, saw it in kids. And then now you're beginning to see it in the literature.
What do you do when a person has a problem and you can't get them into a treatment program?
Ooh. That's such a challenging question because what we know is we don't have enough treatment facilities to go around. And hopefully my colleague who's going to present next may be able to talk to this a little bit, but because I work with children and adolescents, that's not my expertise so much, but I do know that it's really challenging. I spent one academic year in Alaska, and any child or adolescent who had a diagnosis was sent to the lower 48 because Alaska only had probably 10 beds for children and adolescents in their entire state, right? So we know that there aren't enough mental health care facilities. And I think we just need to probably talk to our legislators and talk to others in the community to see what we can do to increase the numbers, because we know the problems are there. And I'll leave it there, and hopefully my colleague will present on that.
Says the cases of suicide rose in 2022. What are the risk factors, and are they preventable?
Risk factors for suicide really truly are mental illness, depression, bipolar disorder. Preventable, that's a sticky one, because if you catch anything early enough, you can, but sometimes it's so masked and so misunderstood, and people can hide it. Just like that 16-year-old I mentioned earlier, he was so determined. His grandfather had committed suicide. His father had had many attempts, and for him, that was the norm. And to prevent we had to fight tooth and nail to prevent him from completing his suicide desire. And so preventable, we can try. I can say that's probably the best we can do, is we can try by recognizing it earlier, calling 911, getting the help that we need for that person, even when they can't do it, right? And just, I think I would contact NAMI as well. If you can't get someone into care and you can't find it, I would call NAMI, because they are so resourceful when it comes to that as well.
So it's often hard to find a culturally competent therapist, and I've had to send several packing. How do you find African-American mental health providers? Does NAMI have a resource for that? I know they do, but what do we do?
Word of mouth often, that's how people find me. Yes, I'd reach out to NAMI, I'd reach out to I would reach out to those resources and say, I am looking for a therapist of color, and can you give me the name of someone? And I would ask specifically and not be embarrassed to say, this is what I want. I think too often we think, oh, I don't want people to, maybe I shouldn't ask that question. No, you have every right to ask that question. And I would advocate for myself and say, I want someone that looks like me, because there's so much now in the literature that says people do better when their doctor, therapist, nurse, and whomever they're working with looks like them. So no one should feel offended by you asking that question.
Okay. Okay. Many think of depression as stemming from personal troubles or challenges with so much violence in our communities and so many mass atrocities targeting Black people in our grocery stores, churches. What's the impact of these heavy times on mental health, particularly for our young people trying to absorb and understand it without living in fear?
It's huge. It's huge. And we see more and more young people depressed and suicidal because of what's going on. It has wreaked havoc on our society and our race for years and years and years, right? And it's why we are ill sooner. It's why we have more diseases. It's why we don't recover well when we are ill. I personally, I just had to stop watching the news for a while to cope with life. Sometimes you have to do what you have to do to get through this life. But it's huge. And the only way we can survive it is through our relationships with Christ, our faith, our prayer, and our support of each other. And as I said, to get some therapy and talk about it. Don't just let it sit there and fester inside of you, because then your body responds to it. The young guys that were in my study, when they were in my study, they were college students, and now they're in their mid 40s and moving up, right? And they are saying that, they because we talked about it, and they were trying to make a difference because of the study and the exposure. But they said, you know what? And the research shows that a Black man who lives in this society, who changes his life, eats well, exercises, does coping strategies, because of those stressors in our society, by the time that man reaches 75 years old, he looks like someone who lived in the inner city that never changed a thing in life because of the stressors. How do we, that's God, I think, is the only way that we can counterbalance that. And it's really challenging.
Well, thank you so very much Dr. Kendrick, you are right on time and we are right on schedule. Thank you, everybody, for your questions. We're going to move our program along, and our next speaker will be Dr. Jimmie R. Turner. Let me tell you a little bit about Dr. Turner. He is a senior consultant who serves on the Ethics and Program Advisory Committee of Visions Incorporated. He is a professor of psychology at John F. Kennedy University in Pleasant Hill, California, and the University of California, Berkeley Extension Program. Dr. Turner was chief psychologist for Kaiser Permanente's Chemical Dependency Recovery Program in Oakland, California, and a staff psychologist for Kaiser Oakland for more than 23 years. He is an experienced community consultation who was voted one of the 50 most influential members of the Oakland, San Francisco Bay Area for his support of community projects. He is a licensed psychologist who earned his doctorate from the University of California, Berkeley campus. Welcome, Dr. Turner. The floor is yours.
Thank you, and good morning. It's a pleasure to speak to you on these topics, and there's a way in which Dr. Kendricks and I could have shared this together, as there's so much overlap in the work that we do and in the issues that we address. I want to just say that it was fitting for Dr. Kendricks to go first, because substance use and domestic violence are mental health issues. And so to put them next to depression and other forms of mental illness, I think is really important. And we believe that when more than one of these challenges occur at the same time, we're talking about co-occurring disorders. I just love the questions that came. I'm just, at the moment, just kind of full of all of what you all have been raising. Although we think of substance use and domestic violence as individual, interpersonal, and family challenges, the growing violent attacks and murders of Black, Brown, Asian, and other people of color communities suggest that we need to expand this frame to include what I would call community abuse and community violence. Now, we all know this is not new, but it's approaching epidemic proportions at the moment. I'm also going to share slides as well, so if I can figure out how to get this up in a way that, here we go from the beginning. All right. I want to share the objectives of my presentation. I want to set the context of where we are at this moment in time. And as you noticed, my presentation was entitled Substance Abuse and Domestic Violence during the lockdown of public health crises. And so it's important to say that at this moment in time, the lockdown that started here in California in March 19, 2020, and went on for about a year, continues to impact vulnerable communities, and that the idea of our moving to the new normal is uneven, that communities are still dealing with a lot of what happened. And later on, I want to talk about what we all experienced when we were facing the lockdown. It's true that we experienced an increase in substance abuse and domestic violence during the lockdown. And so here are some of the objectives that I want to share as we move through this presentation. I love what Dr. Kendricks was saying about the way in which we are thinking about how to diagnose today. What do we mean? We want to define what we mean by substance use disorders and what we mean by domestic violence. And the language has changed over time to be more inclusive and less stigmatizing, because both of these areas are areas where people have been stigmatized and blamed for their plight, if you will. And now, okay, I saw something in the chat. I hope people are able to see what I'm showing. I also want to talk about what we know about the causes and consequences of substance use and domestic violence, and then the impact that the COVID lockdown had on these, both separately and in combination, because these things don't happen in a vacuum. They interact with each other. And then to talk about some of the contributing factors in our society that furthers this public health crises. So let me just say that the pandemic and the subsequent quarantine definitely led to an increase in substance abuse, while reducing opportunities for substance use treatment and services. So there was this double thing that went on, that more people were abusing, and people who already had problems had disruptions in their treatment opportunities, and people who needed treatment had a difficult time acquiring treatment. Many scientists had predicted that social distancing, stay-at-home orders, and quarantine measures that needed to be in place to contain the virus during the pandemic inadvertently led to worsening of mental health and increased substance misuse and incidences of domestic violence. And I want to go to the next slide, and this one is important. According to the Center for Disease Control, as of June 2020, 13% of Americans reported starting or increasing substance use as a way of coping with stress or emotions related to COVID-19. Overdose has also spiked since the onset of the pandemic. We also know that from the National Domestic Violence Hotline, that when they began to collect data and to track the impacts of the pandemic on victims and survivors of domestic violence, that external factors that add stress, isolation, and financial strain can create circumstances where a survivor's safety is further compromised. This pandemic had all three elements of these safety factors or unsafe factors. Even more concerning, shelter-in-place orders meant that many would be closer and in more frequent proximity to their abusers. And then the last thing I want to say about COVID and its impact is that when these two things come together, increase in substance use and domestic violence, it's well documented that that they support each other, and that crises in our community furthers their existence. We saw that following the eruption of Mount St. Helens and Hurricane Katrina, there was an increase in alcohol abuse and domestic violence. We saw that when the SARS epidemic was present and the H1N1 pandemic occurred, people were feeling isolated, facing psychological distress, loneliness, depression, PTSD, anger, sleep disorders, and problematic use, as well as increase in domestic violence. I think it's important that we put a face on these issues. We know that there's been an increase, and we know that the combination of the two interact with each other. But let's give some examples of what does this look like. So take a moment and reflect on a 38-year-old Black man with 2 years of abstinence from alcohol and cocaine use, laid off from his job as a chef due to the lockdown. Unemployment checks were slow to process, and his 12-step meetings had not yet transitioned to online meetings versus the in-person meetings. He relapsed on alcohol and drank liquor that was in the house. He then began to purchase and hide alcohol when he went shopping for food and supplies. He reached out to the drug treatment program and was not contacted for 7 days. When his restaurant reopened for takeout, he was unable to get to work on time due to hangovers and transportation costs, which he did not have the money for. He binge drank after the news of another police-involved killing of an unarmed Black man. He was suspended from his job pending drug and alcohol treatment. So if you can hold that, and then think about a 40-year-old woman who said that there was nothing safe about staying at home during the COVID-19 pandemic. That being home meant being stuck with her abusive husband, who beat her and tried to control her every move. The abuse predated the pandemic. Her 3 children were sent to live with the family members in 2018 because of it. But when her husband lost his job because of the shutdown, he became angry and bored, and the violence escalated. Every day he would surveil her over Bluetooth while she continued to work her job at a trucking company. He'd wait to make sure she arrived home immediately afterwards without time to stop anywhere on the way. When she walked in the door, he'd take away her cell phone, paychecks, and keys. And when he got upset, which happened even more frequent as the pandemic wore on, he became dangerously violent. She said, I was getting beat because he had no money, because there was no meat at the market. Everything became my fault, and I just became a punching bag. So you not only can hear that these were not new issues, but they certainly increased and became problematic as people were locked down. I want to move to how we begin to define and think about these issues. And just to say, Dr. Kendricks talked about self-medication, that if we think about the level of stress and the level of violence and the level of discord in poor Black and vulnerable communities, it's no wonder that people aren't engaging in self-medication to deal with the stress of all of that. We also know that that with substance use, there is a moral and spiritual decay that occurs where people begin to feel a loss of contact with the divine, and some of the treatment is about to help people reconnect. But as I said earlier, we used to talk about substance abuse and addiction. And the DSM suggested that we need to talk about patterns of symptoms that result from people engaging in the use on a regular basis, and that then causes negative consequences. Now, we know from the old medical disease model that if you drink on a regular basis daily, or take other mood-altering substances daily or multiple times a week, that at some point it will shift from recreational use to habit, to using habitually. And this happens because tolerance sets in, and we need more of the substance to get the desired effect. And that if we continue, once tolerance is set in, we continue using the substances when it has negative impact on our health, on our relationships, on our jobs, et cetera, et cetera. And the new way of thinking about it is that there is a continuum of severity and that it gets worse over time. And so a small number of symptoms can indicate that a person is at risk. 2 or 3 criteria can point to mild substance use disorder. 4 or 5 symptoms would lead to moderate substance use disorder, and 6 or more would lead to severe and probably trigger the signal of addiction, excuse me. And just to give you an example of what these few criteria are, at the earliest end, the end where the risk is less, using more of a substance than intended or using it for longer than you meant to is one criteria. Trying to cut down or stopping use, but not being able to do so. And then as you get to the more severe, giving up important or desirable social and recreational activities due to substance use, and then using substances in risky settings that put you in danger. And then lastly, continuing to use despite the substances causing problems with physical and mental health. We know that that in vulnerable communities, substance use on a regular basis is overwhelming. We did a study once where we looked at the number of liquor stores in Montclair compared to the number of liquor stores in East Oakland. And I think at that time there were 2 in Montclair. And there was a liquor store or places to buy liquor on every other street in East Oakland. We also know that in the poor communities, cheap, highly potent, and readily accessible substances is the primary cause of substance use increasing in those communities as well. And so if you go into stores and you see all these fortified beers and these cheap forms of alcohol, and they're sitting right there up front in poor communities where they're on every street, every other street corner in the community. And so there's no wonder why we have a problem and why the problem got worse during the pandemic. I want to shift us to looking at how we think about domestic violence. We used to call it domestic violence, and now intimate partner violence has become a way to talk about it as well, and that it encompasses many different types of physical and emotional abuse that affects health, safety, and quality of life for women, men, and children worldwide, regardless of sexual orientation or socioeconomic status. And, you know, in terms of stereotypes, there's been the belief that upper class privileged women aren't necessarily the victims. And research is suggesting that that is absolutely not true, that this challenge affects every level of our society and impacts. During the pandemic, it certainly impacted our emotional well-being. There was emotional and verbal abuse, which is the most common form of intimate partner violence or domestic violence. Physical abuse, economic, financial abuse, the ways in which you restrict people's ability financially, the digital abuse, using technology to stalk, to bully, to do other forms of abuse, and then sexual abuse, which involves the realities of rape that can occur when when, and even in a marriage, when someone is not willing to engage in an intimate sexual encounter. I think it's important to give you just a little bit of the statistics that we know, that 4,774 women in the United States experience physical violence by an intimate partner every year. And 1 in 4 women will experience domestic violence during her lifetime. The leading cause of homelessness among families, the third leading cause of homelessness among families is attributed to domestic violence. Each year, 2 million injuries and 1,300 deaths are caused as a result of domestic violence. And 3 women are murdered every day by an intimate partner. 3 women every day by an intimate partner. Let's take a moment and think about that. And then when you add the combination of people who are struggling with drugs and alcohol to this picture, we really are dealing with a crisis, a public health crisis of epic proportion. I know my time is, I don't want to take all of the time, but I do want to say something about contributing factors. How many of you remember during the pandemic, the conditions under which we were facing? There was a period where police violence in the larger community was growing, and we were forced at home to watch some of the most horrific forms of that violence. We also lived through a campaign and an election that had lots of hate and that had lots of other stressors that we were dealing with. We saw the rise in hate crimes throughout this country. Our environment was struggling, and so fires were happening all over. And some of you might remember that day when the fresh air, when we didn't see the sun and the air was polluted for a full day here in Northern California. Hospitalizations, deaths, losses, and funerals were epidemic. And many of us lost loved ones and couldn't ritualize the loss in the form of a funeral because of the virus. Shortages of food and supplies were happening, and people were hoarding who had access to food, and people in food deserts were struggling to get food donated in order to eat. And we have the cultural support of the use of violence to solve conflicts in our society as well. If I can do 2 more things before I stop.
Right ahead, you have a good time.
Am I okay? I want to talk. I want to talk about cultural. That we know that if you grow up in a family where the family endorses drinking alcohol and using drugs as a way to deal with stress, or you grow up in a family where the family endorses using violence as a way to solve conflict, you're likely to internalize that and repeat that in your family and repeat that and pass it on to your children. And so I want to talk about the way in which we get cultural messages about feelings and how that links to the ways in which violence plays out. This feeling wheel is on the web, and any of you can access it. But if you notice in the center, there are 6 feeling families. They are mad, sad, scared, peaceful, powerful, joyful. And if you move outside toward the outer circles, you get more thinking embedded in the feelings. And so If I make you mad and you tell me you're feeling skeptical, which is a thinking response, I might not know that you're mad, because skeptical doesn't sound like mad to me in my experience. And so it's important that we think about our feelings based on these 6 feeling families. This is one model. There are many other models. And that by powerful, we're talking about the power of accomplishment, not power over another person. So when I learned to ride a bike, I felt powerful. When people learn to speak a foreign language, they feel powerful. And so we want to talk about how these feelings can help us understand what we need to do to take care of ourselves. We know that if someone is feeling sad, and there was lots of sadness during the pandemic, it's generally because there's been a loss. And the loss can be based on death, or it can be based on loss of a job, loss of a friendship, loss of the continuity of our lives. And we know that loss leads to depression, as Dr. Kendrick pointed out to us earlier as well. If we can identify what the loss is, then we can provide the individual comfort, space, and time to grieve and let go, which is really, really important. We know that if someone is scared, there is danger. And it doesn't make any sense to tell people there's nothing to be afraid of. But if they can identify what the danger is, we can provide the protection, the support, the reassurance to help them deal with being scared. If someone is mad, then there is a violation. Someone has asked you to do something that you weren't prepared to do, or they've taken something from you that you didn't give them permission to do. You've been violated. And so the need to set a limit and to reestablish boundaries and expectations is a way to resolve that. And when we resolve sad, scared, mad, we rest in feelings of peaceful, powerful, and joyful. They can be resting states. I want to talk about male development, that I grew up Black male in America, and I had permission to be mad and to show mad. And I can show mad in 1,000 different ways. I learned to experience, to share mad without ever becoming violent, because I had permission to express it. But if you ask me to cry, I mean, even in my mother's funeral, I struggled with the freedom to just be in tears because I was feeling all that sadness. But boys don't cry, men don't cry. The men in the church told me, be strong. And so we get these cultural messages about what's okay and what not's okay. And they have consequences to our relationships. And when you add that message to a notion that violence is the way to solve conflict, then we have equipped or prepared men to engage in violent interactions in ways that is costly to themselves, to their relationships, and to the community as well. And so I think it's really important that we begin to look at, what are we teaching our children? What are we teaching ourselves about the ability to think about how we're feeling and what we need to do about it? And then the last thing I want to talk about are the 4 levels of our community in terms of where these issues reside and what we can do about it. That in every city, in every company, in every organization, in every church, there are these 4 levels. The personal levels is the level of the values, the beliefs, the feelings, attitudes, and opinions that we all either were taught or we caught growing up in the world that we grew up in. So some of us were taught that people who abuse substances are weak and aren't putting in the work in to do what they need to do. And some guys were taught that women who are abused deserved it. That's at the personal level. And we need to do something to unpack some of these messages that we caught and were taught growing up. When we begin to interact with others, we access the interpersonal level, and this is where abuse occurs. This is where we treat people. This is where we stigmatize people with substance abuse. This is the place where the consequences play out, if you will. The institutional level is about the policies, the practices. How much money are we spending on prevention? Are we allowing harm reduction approaches to be in our community? What are we doing? What are the practices, the procedures, the rules, the laws that can support addressing these issues? And then lastly, at a cultural level, you know, the shared values, the group dynamics that play out. Who do we engage with culturally around these issues? When was the last time you talked to a woman who is the victim of domestic violence and engaged with her? When was the last time you interacted with a homeless person with a substance use disorder? All of those are cultural ways in which we live out our lives, and they can support change and they can support oppression as well. And so I know this is a lot, but where do we go from here? We need more education, more awareness, and we need more destigmatization at the personal and at the interpersonal level. We need to make contact at the interpersonal level. We need institutionally more support, community resources available. One of the things that I have done for many, many years is supported Alan Temple's domestic violence and substance use programs and have trained the facilitators in this work, because the public sector sometimes is too expensive and unavailable to our people, and we need access to these community challenges and treatments of them in our community. We need to advocate for harm reduction resources and preventive approaches. We need to address violence directed at vulnerable communities due to hate, and we need continued community forums on health and well-being. And then the last thing, some resources. I would just add to the resources that Dr. Kendrick's the hotline for domestic violence is really a critical and important resource as well. Thank you, and I will stop the screen share.
Thank you so much for that great presentation, Dr. Turner. We're going to open the floor for questions. You can type in the chat, you can raise your hand, and we will address them. I have one question that came in that says, filicide rose, how can we prevent it?
Say that again.
So filicide rose, and filicide is when parents kill their son or daughter, it rose, and the question is, how can we prevent it?
You know, it's an interesting and very painful process to think about how dysfunctional, how oppressed, how separated from other human engagement that would lead parents to kill their children, and adversely to leave children to kill their parents, which we've seen that happen as well. And years ago, there was a study that pointed out that boys who attended some Sunday school were less likely to show up in prison. Ooh. And I think that has to do with families that are so alienated from others that they get into a place where they have no choice. And we probably could tie all kinds of things: increase in substance use, domestic violence, poverty. All of those things are probably contributing factors, if you will, to that phenomena. And I think all of it plays a role, if you will.
Yeah.
And Dr. Kendricks, if you had anything to add, please feel free, because these are not discrete issues, if you will.
And those of you, please feel free to put your questions out there for either one of our speakers. So I have a question. How do you deal, even if you turn off media and don't watch it, it doesn't necessarily make it go away. It just makes it not visual. And this past week, with rights being discussed about ultimately being taken away and Black folks being murdered and hunted down like dogs, how do you decompress from that?
Yeah, that's a really good question. I certainly limit my engagement with those news channels. You know, I don't watch them 24/7. They are very distressing. I think it's really important to have a group of people that I can connect with to say, you know, I'm really struggling with what's happening today, and I need to go for a walk and to be able to put it in perspective. So I'm not losing sleep over it, although it's worth losing sleep over it. I don't want to minimize it. You know, this notion that you know, yet another mass killing of Black people. How are we supposed to feel about it? Well, I hope I will always feel devastated about it. And I hope I will have people who will help me put it in perspective so that I can sleep at night and I don't have to drink over it and I don't have to do harmful things as I take that in. So I think some human connection, some support groups can really be helpful to address the issue as well.
And also, we can get out there and do something about it. We can take action.
And we can take action, yes.
Next question is, can you talk about the inter and intrapersonal discussions about arming ourselves in the light of the Buffalo Massacre?
You know, one of the things that I am excited about is that I'm an elder. And I've been around a long time. I was around when the Panthers were alive and well and doing really good things. And I know what the consequences of all that was about. It makes sense to me that people are having these conversations because the conversations in other communities are happening as well. I happen to believe that change is not going to come about through armed insurrection, but through mass. When the masses of people get fed up with the ways in which things are happening, we're more likely to see change occur. We saw this in the civil rights struggle. We saw it in other movements as well. And I think it makes a lot of sense that people feel like they need to arm themselves.
Okay. So how do we discuss these difficult issues with church folk who prefer to avoid these horrors by saying, we just want to come and worship?
Well, I remember Mother Emanuel.
Yeah.
I mean, that white supremacy hate wants to impact every aspect of the lives of Black people. Church, now grocery stores, recreational activities, and that it's one thing to be unaware because we just didn't have the information. It's another to feign ignorance in the face of overwhelming information. And I think about my Sunday school teaching about the Pharisees who just walked past everything that they didn't want to see and the consequences of that as well. So I don't know. I'm not a minister, so.
Okay. So how can we work on the growing anger between Black women and men?
Yeah. As the question came up about where do you get a culturally competent therapist in the other talk, and I get a lot of requests from Black women to can you do couples therapy, and essentially what that means is can you fix him? And so I get real clear that that's not what couples therapy is about. It's about mutual change on both parts. I think it's important for us to remember that that the broader society needs Black men and women to be divided. That this is part of what lifts up a white supremacy culture. That the way in which we fight with each other at any level is furthering another narrative, and that you know, there is a history of Black male-female relationships all the way back to slavery, if you will, and the ways in which that was played out. I think it's really important for some discussion around joint responsibility, that we both play a role, and can we have conversations that recognizes challenges on both sides, as opposed to only naming toxic masculinity as the problem. Definitely is a problem, definitely needs to be lifted up, but also on the other side of it are the other things that that come from the other side as well.
Okay. Do we have any questions from, let me see if I have any hands raised. I don't have any hands raised. Do we have any other questions that we want to ask our two panel experts?
We have one last question down there.
Okay. Do you think it would be worthwhile to have church-wide groups after incidents like Buffalo?
Oh, absolutely. I think that there ought to be facilitated groups among the practitioners around, you know, what's the scare? This goes back to depression. That I went to Lucky's, which is not too far from where I live, and the police car was sitting out front, and it was clear to me that there's some attempt to kind of pay attention to what's happening around grocery stores since this incident in Buffalo. And I was aware just momentarily that I was feeling a bit uneasy in ways that I hadn't felt. And so I think it would be important for people in the church to have a place to talk about that. You know, it's one thing to ignore it, it's another to have it bubbling up inside you and not having a place to talk about it. Because I think that then leads right into depression and further stress in the community as well.
You know, I'd like to just add this too. I know that I know some churches who have had groups that are meet weekly, and you're invited to come in and you can talk about the stressors that you're going through, right? And it's a way to help decrease the likelihood or the risk for depression without having to know what the right thing is to say, but to have that open forum so that anyone who's not feeling good or safe or whatever has a place to go. And for many, it is the church. And to have it in a church really opens up an opportunity for many people who might not otherwise get treatment or therapy to have a place to really vent and share.
Yeah.
Mm-hmm.
That is so very true. Well, thank you so much, Dr. Kendrick and Dr. Turner. Our next phase of our program, we will be hearing from Brother Derek Felton from Bethesda Counseling Services. Brother Felton is an Army veteran and a member of Allen Temple since 2010. He currently works for Vitus Healthcare as a social worker, and he is an adjunct professor at De Anza College. Mr. Felton is the Board of Directors President for Allen Temple's Health and Social Services Ministry and one of the core members of Bethesda Counseling. And also, just in case you guys didn't know, Bethesda Counseling listed that you can go to their website and get a listing of therapists for Black folks. Thank you very much. Brother Felton, the floor is yours.
Good morning, everyone, and thank you for allowing me to come and greet you this morning. I'm currently in my military uniform because this is my drill weekend. And so just wanted to say happy Military Appreciation Day and to all our veterans. As stated, I am one of the core members for Bethesda Counseling. And so I just wanted to talk a little bit about some of the other core members, as well as some of the services that Bethesda is doing. Our advisor is Dr. Alvin McLean. Reverend Timothy Dowles is part of our core team. Reverend Lorraine Allen, Sister Deborah Richardson, and Sister Rika L. White Soso is our clinical coordinator. The services that we've been providing to Allen Temple Church, the ministry, our ministry leaders, as well as our church members and surrounding community, information and referral, consultation, education. We've also been doing training and workshops from depression, grief, stress management, some of the topics that our panelists have discussed. Bethesda, we've been able to provide a brief overview with some skill set and some learning techniques of how to manage stress. Right now, Bethesda is currently still developing its infrastructure in order to safely and confidentially offer individual, family, and other modes of therapeutic services. Again, thank you so much for allowing me to come and speak with you briefly. I am open to your questions.
I don't have any questions in the chat. Let me see if I have some hands raised. I do have a lot of thank yous in the chat from everybody for a great presentation. Well, I'm not seeing any hands raised, so I have a question. Since you're in the military, how does the military deal with depression for their Black members? Do they?
So I am part of the State Guard, and the State Guard is a volunteer unit. And so I prior military myself. So usually when there's any type of stress, it is upon us to get together and pretty much talk it out. So we have our Black African chaplains that would come in and provide an open space. I think the question earlier was like, after an incident, should the church provide an open space? And so in the military, we have what is called a check-in. And so the chain of command would call on that list every member to check in. And especially being Black descent, we do that as a check-in just to call and say, hey, did you see the news? How are you doing? And do you need anything? And so it's about that word of mouth. As Dr. Kendrick stated, it's not about trying to fix it, trying to find an answer. It's about allowing that person just to have their space and to vent and be heard and be supported.
Okay. So I'm not seeing any further questions, and we are really, really good on time. I can't thank you enough for all the wonderful information that was provided. I want to let everybody on the call know that this will be on YouTube, so you can pass it around to your friends because it was a lot of valuable information. And we are now going to have, before we close out, let's give a big round of applause to our speakers and thank them so much for their time. And now we'll have a closeout with Sister Carolyn Swinton, a closing prayer, because we always need prayer always.
Heavenly Father, giver of life and health, we thank you for this meeting, this beautiful day and meeting. Thank you for blessing us with knowledgeable speakers and the information they shared. Let what was discussed here bear fruit and make a difference in our lives and the lives of the community. Give your power of healing to those who minister to their needs, the needs of the community, that they may be strengthened. Thank you for this church, our Pastor Emeritus, and the members of this health ministry. May the information shared here be used for your glory. In Jesus' name, amen.
Okay, thank you. And before everybody leaves, we have a survey at the end before you sign off. Please, please, please complete the survey. We use that information to set up other symposiums and workshops that we will be hosting. And somebody put in the chat, how do people access counseling at Allen Temple Baptist Church? I'm gonna actually go to our website, and and you can always send a question in, and we have a lot of information on our website, allentemplebaptistchurch.org.
You have another question in the chat. Is it possible for males to associate in brotherhood while simultaneously uplifting joint male and female non-sexual associations where frank discussions are had?
Anybody want to take that question before we exit out of here?
I would say that it's not only possible, but it would be helpful. I think that the challenge is that it's hard for men to prioritize coming together and talking with each other. And if we can do that, it really makes a difference. So I'd say right on to that suggestion.
So I also want to add, it was interesting during the research and the focus groups, a lot of the guys said, you know, men don't talk. But I beg to differ. We don't recognize their talking sometimes. We expect it to be one way, but stand outside on a basketball court, go to a game. Men are talking, and the guys in my study, I had to go back to the IRB to get approval to extend our meetings because they gave me 2 hours. These guys were talking so much. We met for focus groups that went 4 and 5 hours because they had so much to say. So I told them, you have to stop saying you don't talk. You do, just pay attention, be intentional about it. But I do believe that when those men were talking, and we look at them now because we always talk about, let's go back and see where they are now. It helps them to be better in their relationships with everyone around them. The guys that were part of our study are married and getting along well with their families and being great dads. And we also often say, is it because they got so much out during those focus groups and sharing so much of themselves, right? So I think instead of thinking that they don't talk, let's give them an opportunity and a venue where they can just talk, because they do.
Thank you so very much for that additional information. I want to thank everybody. Continue to have a blessed day, and stay tuned for our next workshop, webinar, and symposium coming soon to you. And please complete the survey as you exit out. Thank you so very much.